as we need. So the learning objectives are on the screen. I'm going to talk a little bit about racism and health. Looks like this group probably knows a good amount of that. And then I'll really get at the specifics of how racism shows up very specifically for women of color in very different and unique ways that I think we need to be considering, both in our health services, but also in how we think about policy. And then I'm really going to push us to understand how seemingly race-neutral policies actually perpetuate racism and how that's uniquely experienced by women of color, and particularly Black women who experience both homelessness and unstable housing. I start all of my talks with this quote because it took me forever to figure out why the frame of social determinants of health in the beginning of my career really just didn't sit well with me. And it's because I had this whole long history and this whole long understanding of the incredible work of Black scholars. Particularly, this one is from W.E.B. Du Bois. We talk about him as the father of modern sociology. And I read this quote purposively so people can hear it. And if you don't know who he is, he's the first Black man to receive a PhD in the United States from Harvard University. And in 1906, he challenged the bleak forecast that was countered in arguments of inherent Black inferiority. And there was a health conference in Atlanta, Georgia, and those written proceedings were called The Health Physique of the Negro American. And the interesting thing he pointed out, the conference findings showed that the impact of environmental and social conditions on Black morbidity and mortality rates. And commenting on the higher Black rates, he noted that the present differences in mortality seem to be sufficiently explained by the conditions of life. And I think that this is one of the most important and first descriptors of social determinants of health. So we've been talking about this for a long, long time. Before we begin, I know a lot of people get tripped up on how we define race. So I always like to talk about how I define race and what I think is important for healthcare teams and for people who support people seeking health services to really understand about race. For those of you who remember your high school biology, this is the human karyotype. This is the human genome and our chromosomes all lined up in the way that we conceptualize it to understand, the genetic contributions and the unique contributions of our genome and our physiology to how things occur in our lives. And in 1994, when President Clinton and J. Craig Ventnor and our current director of the National Institutes of Health, Francis Collins, all declared that we had mapped the human genome, people were actually surprised at how similar humans were across race, across ethnicity, and realized that we had not found any gene for race. When we moved further along the Human Genome Project and we started to characterize genes by the transcribed proteins, we realized that there also was no protein for race either. So what is race? How do we think about it? And why does it matter for health, and why does it matter for health of individuals who have unstable housing? And what's that relationship? Well, let me posit, and this comes from a good colleague and collaborator, Dorothy Roberts, who is an endowed professor at the University of Pennsylvania Law School. She's a lawyer by training. She states that race is a specious classification, where specious means fake or false, classification of human beings, with Europeans being the standard model of intellect, morals, and culture, with the sole purpose of upholding white privilege. But I argue that race is actually a shortcut. It's a crude proxy for a whole lot of other important things, whether it be muscle mass or enzyme level, genetic trait, family history. And so for a lot of people, race doesn't really provide a lot of relevant information. I think as clinicians, for those of us who are clinicians on the call, that race sometimes overwhelms some clinical measures that we should be really, really considering, that it sometimes blinds us to the symptoms that people report, the illnesses that are experienced in families, again, going back to that family history, I think that there are important clinical measures that we need to be considering where we use race as a shortcut or a proxy. But race doesn't tell us what racism is. And I think a lot of times people confuse race and racism. My good friend who's a physician, Dr. Joya Creer-Perry, who runs the National Birth Equity Collaborative, who was one of the founding members of the Black Mamas Matter Alliance, of which I am a member, really talks about that there are levels of racism and that racism actually really should be the risk factor when we talk about health conditions, including housing instability and homelessness, because the only thing, in my opinion, that race does is overexpose you to racism. I always say that black skin inherently has no real function except in a social context to overexpose you to racism. Dr. Kamar Jones, the past president of the American Public Health Association, gave us a list of levels of racism that she reported out in the American Journal of Public Health. And she talked about institutionalized racism, which is nothing more than having differential access to goods and services or opportunities by race, that you have an inherited disadvantage or an inherited advantage. She also talks about personally mediated racism, which I think a lot of us experience, which is prejudice and discrimination. It happens at an individual level among and between individuals. Internalized racism is one that really struck home with me because you internalize or you accept that the negative messaging around your race, your own abilities, and your own intrinsic worth. And this was a very, very helpful framework to get me to understand that the levels of racism a lot of times are conflated, such that if someone discriminates against me as a black woman, you know, that, and it's an interpersonal issue of racism, that's very different than understanding how structures and institutions participate in racism. And I'm hoping to tease that out so that we as a collective community who are really, really geared toward, you know, ensuring best practices and standards of health care for people who are marginally housed or homeless, have access to those services and receive the best care as possible, that we understand at what level racism is being experienced and embodied, and that will help us build better policies specifically around housing. So going back to the learning objective 1, to understand the impact of racism on health, I would like to argue that structural determinants contribute to social determinants of health. So if poor transportation, if inadequate access to nutritious foods, homelessness are all social determinants of health. I would say that there are structural determinants that contribute to that. And that I think that poverty is a structural determinant. If we think about policies and how we allocate resources, and when you think about resources, people always think about money. But I would push us to think that resources are also human, people, to do work, and time. So it's not just money around policies when we want to think about social determinants of health. We want to think about humans and time and the resources that are included with those things. In clinical interactions, a lot of times we don't understand. Everyone thinks that you have to be called a terrible word or that you somehow have to be discriminated against because you have public insurance, or that someone belittles or demeans you or disrespects you in a clinical encounter. But I would argue that racism in health actually shows up if we have implicit bias where we're not able to recognize signs and symptoms of deterioration, or if people tell us that they have symptoms of things and we don't believe them. But there are different ways that racism can actually show up in clinical encounters. I also want to lift up the work of our colleague and collaborator, Dr. Tony Aiton, who talks about that our zip code is more important than our genetic code. So when we think about access to health services provision, we can argue that when highly resourced areas have access to good clinical support or good housing policy, that is a structural determinant of health because it's just a factor or happenstance to where you live. If we think about learning objective 2, what's so special about women of color who are experiencing homeless that makes this very, very different than, say, the lived experience of others who experience homeless? Well, I would argue that women of reproductive age, at least the way it's experienced in urban centers and specifically in San Francisco, are overrepresented in individuals who have housing instability and for individuals who are homeless. I would say that there's some very specific policies related to public housing, number of children that you have, the temporary aid to meet for families, and how families are made and supported that are actually harmful to individuals and can contribute to unstable housing. I'm going to show you some data from the San Francisco Bay Area that was collected with community-based women and some Masters of Public Health students that will make this point more clear a little bit later on in the presentation. So the UCSF Preterm Birth Initiative, which is a multi-site, multi-sector, philanthropically funded program that is really looking to develop transdisciplinary research infrastructure in San Francisco, Oakland, and Fresno to really, really turn the needle on preterm birth or early birth. Took a very, very ambitious view of prematurity and decided that we wanted to focus our community work in San Francisco on housing and pregnancy and preterm birth to really interrogate, deeply interrogate, what is so unique about unstably housed women and risk for homelessness, and what can we do as a community to mitigate those unique factors. This was a community academic partnership, again, between a group of individuals who we funded for a full year called the Benioff Community Innovators, who were modeled after the Oakland Community Innovators, which is a community-based program that really trained community members to be co-researchers. I completely believe in the capacity of community members to be able to design studies and tell us exactly what they need. So this community-based participatory action research project was in partnership with San Francisco State, of which I'm an alma mater, and the Masters in Public Health program. And this is a great way to engage learners and students in your work as we think about what are the different strategies that we can use to be able to find new and innovative ways to resolve homelessness and unstable housing. The students really, really pushed us to be bold and really, really invigorated this project, and I want to specifically shout them out. So let me give you some background as to why we chose homelessness and housing as our focus around preterm birth. Women who live in public housing in San Francisco, particularly single-room occupancy hotels and shelters, we already knew they had a higher risk for poor health during pregnancy and postpartum. And if you look on the left, you'll see in standard housing. And when you look at public housing, single-room occupancy, and traditional shelter, you see on all indicators, whether it's hepatitis C, hypertension, diabetes, and preterm birth, that health outcomes for individuals who are not in standard housing were almost 2 to 3 times higher and had a 2 to 3 times higher risk for all of those conditions. We already knew this from public health data in San Francisco. And the purple bar, in specific, hypertension is also highly associated with preterm birth. So when you look at the purple and the green bars, you will see that this is way above the city standard rates in terms of if you are permanently housed and not. So we already knew this going into our project. And one of the things that we found is that many of the low-income pregnant people in San Francisco and their families, they only have few choices to live, because I don't know, like many of you, San Francisco Bay Area, especially during tech times, and I've lived here since 1993, so I've seen multiple iterations of our housing issues, particularly in the rental market, becoming extremely unaffordable, not only for low-income individuals, but specifically for low-income individuals who have families and children. And so many individuals are forced into either unhealthy housing, overcrowded housing, and are forced into homelessness because we have poor access to long-term permanent housing in the city. The students and the community researchers also found that there is a high amount of day-to-day, what we call chronic toxic stress. And that is the stress of just living and being able to get from place to place using public transportation, being able to seek care at multiple institutions. And I own this. I mean, I didn't give a full introduction of myself, but not only am I a faculty member at the University of California, San Francisco in the School of Nursing, but I'm also a clinical staff nurse at Zuckerberg San Francisco General Hospital. And I will tell you that UCSF alone, which is one of the largest employers in the city and county of San Francisco, behind the city and county of San Francisco, by the way, UCSF owns 58 buildings in the city and county of San Francisco. So that alone, just knowing which building you go to and where to seek your care is in and of itself a stressor. And so that came out in the data that was extremely prominent to us. We also found, and the women told us, that they stay indoors and are limited by their physical activity, their capacity to get to farmers markets for healthy, nutritious food, and restrict their travel because they really needed to avoid community violence. But that in turn made chronic toxic stress worse because it increased their sense of isolation. And isolation, we already know, especially during pregnancy and postpartum, increases one's risk for preterm birth, for postpartum depression, and it decreases incentives for breastfeeding or human milk feeding. And we know that those are other activities that improve health outcomes. We found that addressing substance use was super important, and maybe this is news to all of you, or maybe it's not news to all of you, but it was very enlightening for our team to understand that substance use becomes a way to cope with stress and isolation, particularly in this population of individuals. At the same time, substance use is a barrier to permanent housing. And we also found that the substance use wasn't necessarily associated with the pregnant person, but there were people around the pregnant person who they relied on for support, whether it was financial or intimacy or human contact, or were involved in the pregnancy, or were the father or father of other children. It's their substance use that was impactful to the pregnant person, and not necessarily the substance use of the pregnant person. And that added to their stress. One of the things that I think is super important that we address at a national level and at a federal level is some of the rules that are seemingly race neutral around housing policy, but it perpetuates racism. And one of the biggest pieces is the inability to create social networks and to be able to have continuous care, because I think it's important that who's allowed to be, specifically in public housing, really it reinforces a sense of isolation, especially in the single room occupancy world. I don't think we've appreciated the need for connection, especially during pregnancy, the need for mentorship, the need for understanding the role transition of becoming a parent. It's not just physiologically having a healthy baby. but it's also this, my entire universe, my life is changing, because not only if this is my first child, I have to take on the role attainment of being a good parent, but if I have other children, I have to support those children in fully integrating this new human into our family. And if we don't have a stable place to live to do that, then that creates a whole new host of problems. I think that there is a lack of vision and understanding and accountability, at least in San Francisco, to really understand the needs of what housing loss means, of what multiple moves means. That was a huge issue that came out in our focus groups. We have a lot of construction that's currently going on in San Francisco. We've got a lot of attention being paid to the refurbishment of public housing, but moving individuals around, the fear and stress of eviction is really additive to the day-to-day stress that Black women face. And then if they have a problematic pregnancy, there is a need to be in high-risk clinics, the need for multiple levels of surveillance, whether that be non-stress testing or additional appointments, the manage of their existing children, and particularly the lack of affordable child care. And I also want to stop here to also point out that if people don't have the capacity to live with other family members, they automatically lose a low-cost option for child care for existing children. So I just want to put that in the room as well, that if the person who is the family member is also unstably housed, that could potentially provide some of those low-cost child care options, then we're inadvertently removing a potential solution that I think that could be very, very helpful, and an intergenerational transfer of knowledge and wisdom if we could create families in a very, very different way than our policies have been structured. I think also in San Francisco, which I don't think is unique to urban areas, is that our housing and our health services systems are disjointed, and that perhaps that's on us, meaning as healthcare providers, as public servants, as individuals who are doing case management. At some point, we really, really need to advocate for new models of health services provision, whether it's wellness centers on site, where we can actually either have nursing and case management partnerships, or that we think really bold and out of the box and start to think about mobile options, as well as community-driven options where we can receive and perhaps implement some of their ideas about how to be able to really get this disjointed problem addressed at a systems level. One of the things that I think that really also came through from the women that we were talking with is that they really wanted to be engaged in the development of policy, and they wanted to also be engaged in the testing and the evaluation of new policies. And I thought that was like eye-opening to me, because I do all of the work, at least on the health services side and the research that I do, very, very clinically engaged. I always have women with lived experience on my research teams, as people who are either interviewers or individuals who help me look at data. But I actually thought it would be really fascinating of what would the policy look like if we always had someone with lived experience of homelessness at the table with us, and how would it be helpful for us to hear from them at the policy development stage as well as the policy evaluation stage. And I want to push us to start thinking about ways to be able to engage people with lived experience, not just the public, but people with lived experience of homelessness or unstable housing, to be able to do that in a dignified way. And I would also argue never as only or single individuals. We want these individuals to come in teams, and we want them to be paid for their efforts, because I think that those are just best practices for asking individuals to provide us their expertise, because I see communities, members as experts by experience, and we need to acknowledge them as such. So with that, I really want to say three more things before I move to question and answer. The first is I would love for you to acknowledge, I see a lot of people have been using the question and answer box. And I think it's super important that if you have questions, please make sure either of me or other individuals, because I think we all can learn from each other in terms of if you have questions or comments about the work. But the second thing I really want to be able to say is that I think our current environment is very much ripe for new, bold, and innovative ways to think about if we could really take the best of what we currently have, whether it's thinking about home visiting programs from nursing, whether it's not, how can we better be using doulas in the community setting? How can we think about the postpartum period as a potential way to develop expert parents and ways to think about postpartum individuals in a different light, specifically in terms of prioritizing them. I think it's low-hanging fruit, especially given some of the activities that we've heard around paid family leave. I think one of the other arguments we can be saying is, okay, so in the postpartum period, we need to ensure that everyone is stably housed as they continue to develop their families for a year. If we can think about paid family leave for a year, and if we can think about extending those benefits for people who have employer-sponsored insurance, then I think there needs to be an analogous for people who have public insurance and for low-income individuals. And I think we could have that conversation around the development of the future. I also think that in terms of stress and stress reduction, there are three really big things that we as a community can be doing. Number one, I really believe that it is important that in any way that we can, we create respite for low-income women and for women of color. And what that means, that can be everything from opening up your institutions. I know that we have been working on doing this here in Oakland, in part of San Francisco, for simple things like head and neck massage and meditative breathing space. 15 to 20-minute intervals. We have people come in for an hour. We open it up to faculty, students, and staff. We ask our community members to come. I think all of us in the hard work that we do need to acknowledge rest, respite, play, and breaks. And I would love to see us incorporate that as a norm, just period. So the reduction, any stress reduction thing that you can do at any point, no matter how big, no matter how small, within your institution, I would highly recommend that you do it and you invite the community in. The second thing I think we need to be doing as a community of individuals is as we think about pushing housing type individuals, I know that there are activities around pushing individuals like Airbnb and other apps that have a 30,000-foot view of housing, to think boldly around how could we innovate solutions between public housing, temporary housing, and permanent housing. I think we're stuck in those models because we've been so resource poor in terms of humans and time and money. But I think there might be a new way to forge some new partnerships to think about a whole other opportunity in terms of, could we get a temporary housing day sponsored by Airbnb, right? And to have that be a community, industry, tech partnership that we could advocate for, that we could pilot test. I really think we need to sort of innovate within our own innovation to really think out of the box in terms of new partnerships that we need. So again, stress reduction at any time that you can for low-income and women of color. I also think new and untraditional partnerships that we haven't thought of outside of our traditional collaborations. And then the last thing I would want us to think about is, how can we start to move towards community hubs that have everything that individuals need? And the way that I think about this is, the school nurses have taught me this, that if you can get students healthy breakfast, if you can get them the clinical care that they need in the context of being at school. If you can get them the supports that they need, whether it's, tutors or peer-to-peer learning, if we can have place-based strategies that are similar to what we've done in school for individuals, and again, starting with low-hanging fruit, if we start with pregnant individuals, how would we change how we're providing case management, clinical health services, public health benefits under the auspices of, really creating the best opportunities that we can, and also understanding the role of stress and structural racism in the lives of individuals? Because I didn't even present any of the data from my slides around the interpersonal racism that the individuals talked about in our focus group. But I do think a scanning and being constantly mindful of how often and how frequent Black women in particular are bombarded with racist messaging and with racist interactions from individuals. It's very, very constant. And I say this as a person who has 3 degrees from 3 publicly funded institutions, who's responsible for teaching not only the future healthcare workforce, but the future public healthcare workforce, and it's constant. And I think an empathy from us, and I say that as individuals as well as institutions, can go a very, very long way. I always tell my nursing colleagues, if we stepped up and decided that Nursing the Nation was going to be the orientation that we were going to use to be able to dialogue and discourse about how to better improve outcomes, that this would all be different. And so how can we as a community think about stress reduction, especially for women of color, whether it's, I'm late for an appointment, we have to reschedule you, to, wow, we're running really behind, but we're going to, think about some stress reduction strategies we can have while we're running behind. How can we think about the innovative partnerships that we haven't thought about yet? And I'm curious to hear, what crazy things are we not talking about because we think it's crazy? I actually think we should start talking about it. And then the final piece is, how can we create more empathy, not only among and between ourselves, but as we start to make the case as a collective community about unstably housed and homeless individuals? Because I think, we've seen some good photojournalism recently, and I'm wondering, how else can we be innovative? Can we think about, addressing the producers of Netflix? We've seen some good Humans in New York pieces, but how can we start to leverage and be creative and get out of our own boxes to think about how this could all be different? And I very much look forward to your comments, your feedback, your questions, and would love to be able to use the time we have left for a real dialogue about some of the most innovative and out there suggestions that you would love, even if you think it's impossible. What could we be doing differently, and how could we be making this better for the people we serve?
Great. Thank you so much, Dr. McLemore, for your presentation. We'll now begin the Q&A portion of the webinar. If you haven't yet done so, please feel free to enter any questions you might have for the presenter into the chat box. And as a reminder, the CME claim code is now available and will only be available during this session. So please make note of the code if you plan to claim CMEs. And let's get started. Our first question is kind of a question for an expanded comment on. Can you please say more about racially explicit services for women of color experiencing homelessness, compared to the systems now which purport to be race neutral but favor white people?
That's an excellent question, and thank you to whoever wrote it, because I think that's the crux of the issue. So let me first just sort of shout out the fact that I think that, at least in health services and in research, I think that Black women need to be leading. So I always have Black people on my team. And I think fundamentally there are insights that Black women have that other people don't have. So I just want to start at a very 30,000-foot view of if Black women aren't creating the policies, then that's the easiest place for us to start. One of the things that I've been trying to do in my role as a researcher is to push the Congressional Black Caucus Health Brain Trust to be able to think about how can we be supporting community members to more deeply engage in policy. And so one of the things that I think is we need to make sure that there are capacity building activities, whether it's media training or whether it's free community opportunities to be able to have community members to gain skills to participate in the policy process, and then to be able to have them at the table. So that's just number one. If they're not helping to create the policies, then we need to start there. But the first policy I would upend around homelessness that are seemingly race neutral is we need to be able to understand that not all individuals, and this is a reproductive justice principle, not all individuals create family or create kin in the same way. And I say this as a person who is childless by choice my entire life. I live with my male partner, 1 dog, and 2 cats. And that is how I've chosen to create my family. I have, helped people birth folks into the universe. I've helped people in pregnancies. I have been in reproductive health rights and justice my entire career. And I feel like I am the aunt, the fairy god aunt to everyone's children. I have children in my life whose graduations I've gone to, whose births I've been at, who I help to financially support in the world. We all don't make kin the same way. We all don't make family the same way. So our policies should not reflect a 2-person, 2 children, nuclear family that exists in a single space. So the first thing I would say is if a adult person is involved with supporting the pregnant person, then they should be allowed to live with the pregnant person, irrespective of who they are. They could be the father of the baby. They could be the mother of the pregnant person. They could be the fairy god aunt like I am. But that we stop putting qualifiers on who's eligible to support a pregnant person or not in housing that's not standard. One of the other policies that I would ask us to end is the notion that we treat pregnant people differently than we treat non-pregnant people. So that we would assume, and as long as this continues to be true, that pregnant people have bodily autonomy, that we should treat them like every other human on the planet. And so instead of having these special carve-outs for pregnant people, why don't we just suggest that all homeless people need access to permanent housing, irrespective of whether or not they're pregnant, whether or not they have family, whether or not they make traditional kin. Why does any of that matter? And I want us to deeply interrogate why we think that. Because I have the personal assumption that it's because we want to reinforce an idea about family that we think is acceptable to funders in the public. And I would argue that that's a dated opinion. And it remains an opinion in the minds of a small minority of individuals. But nobody's tested that yet. And so, I think we have a perfect opportunity to test that. But why? Because one of the beauties of the Affordable Care Act that I don't think people have appreciated or understood is that it was the first time ever we said that adult individuals should have access to health care irrespective of whether or not they're a single man or they're a pregnant person. So I actually think there are different narratives that we could tell around how people make kin or make population or make family that we haven't thought about in the context of housing or homelessness. And I also think that if Black women aren't leading or helping us to lead these efforts, then we won't be able to get to race-informed policies as opposed to race-neutral policies, which actually are harmful to Black women and to Black families. I hope that's helpful. I'd be curious to hear other people's comments about that question.
Thank you so much. Yeah, I'll keep an eye out for those comments. I want to be respectful of our time, so I'm thinking next question starts, Dr. McLemore, I've read that the field of epigenetics teaches that environmental factors during pregnancy, like stress, affect the expression of genes for generations. How does that inform the importance of failing to address the stress experienced by women of color experiencing homelessness?
That is an excellent question, and thank you. For people who don't know me, I just got back from the Society of Gynecologic Oncology meeting. My dissertation work was actually completed after we mapped the human genome, so I'm very much a lab nerd, and I'm a big fan of the epigenetic work. That said, let's be very clear as we interrogate biological environment as the only environment, because it's not. Right, so one of the critiques that I've had around the DOHAT individuals, so for people who don't know what that is the developmental origins of human disease, or the people who think that there is an intergenerational transmission of stress that can be identified using epigenetics as a proxy. In animal models, we've seen a reversal, especially where there's intervention, appropriate intervention, where those effects, at least in mice, can be mitigated in 2 generations. So I always warn people, let's not act like epigenetics is manifest destiny, right? I started my talk specifically saying I was born in preemie in 1969. I didn't tell you that my mother retired as an investment banker and my father is an Ivy League educated judge, right? So I actually at the time didn't have any real social determinants of health that people would think that black people would have, that why I should have had a poor birth, or why my mother should have had a poor birth outcome, right? At the same time, my older sister and my brother were both born full term. So let's not think that the pregnant person is the exclusive environment where epigenetics plays out. Because if the pregnant person, who is the epigenetic environment for the developing fetus, doesn't have clean water, i.e. Flint, or if they don't have access to nutritious food or the broader environment in which that pregnant person lives and exists is not considered in the context of epigenetics, then I think we need to be cautious in how we interpret those findings, right? So one of the things I also always say to individuals that I think is super important is, like right now, a lot of my work is focused on maternal morbidity and mortality. The statistics we see on women dying during childbirth and pregnancy are equitably distributed across socioeconomic status and educational attainment, and I would even argue wealth, as well as like national prestige. Because if we have people like Serena Williams, reporting her birth experience in Vogue in January of last year, and we have people like Beyonce talking about toxemia pregnancy, I would argue these are 2 of the richest black women in the world and 2 of the most fit black women in the world in terms of their physical fitness and access to great food. That the things that are protective for white people are not protective for black women. So when we think about epigenetics, however, one of the things that I always like for people to understand is it's not a manifest destiny, and it is not, a reason for hopelessness, that, oh my goodness, the intergenerational transmission of stress somehow, confines you to a poor birth outcome. I don't believe that, and I don't think that that's true. I think what we need to understand is that's a snapshot of the environment that a potential human has to deal with when in utero. But that's not the extent of the entire environment that's impacting those factors. That said, I think that pregnant people need to go back to being the revered harbingers of the human species that they are. I always remind people that if people didn't birth, we wouldn't be here as a species. So that there is a certain reverence that we need to have towards birthing individuals. I also think that from an epigenetic perspective that we need to start seeing precision public health epigenetics, where not only are we looking at the transmission of stress in epigenetic markers, but we're also looking at access to health services, we're looking at food, we're looking at nutrition, we're looking at micronutrients, and we're also looking at the assets of those individuals. I'm one of these people who thinks that if we started the scientific enterprise, not from all the things that are wrong with black women, but it's very curious to me why we're not extinct, given that all the things that we've survived. I'm sort of curious around how that would change how we ask research questions and how we think about adaptation to environment. So I think that question is a very interesting one. I think it's an amazing one. I never think it's an either or. I always think it's a both and. And again, that's a perspective that comes from reproductive justice, that there's not just one way to look at things, that there's not just one way to think about things. So I think, looking at DNA methylation or looking at telomere length and looking at all the pieces that go along with epigenetics is an important one. But I also think that it's incomplete. And we actually have to look at, okay, if once you lose those things or they're overexpressed, is that permanent? And does it have to be? So that's all I'll answer that question.
Thank you. Yeah, we have a lot of great questions here. So I just want to send a reminder that anything that's not answered during the presentation will be logged and sent to Dr. McLemore for answers.
Yeah,
so,
and I will happily make
changing topic just a little bit. I wanted to get a question in here from Joe. He says, I'm currently a peer navigator at a day shelter for women and transgender people experiencing poverty and homelessness. As a white male, I'm wondering what are some ways that someone like myself, who is not part of these marginalized groups, can be part of the solution in addressing systemic racism and gender inequality? In other words, what is a way that a white male can be a part of the solution without being paternalistic or unintentionally acting like a white savior?
That is an excellent question, and thank you for it. So I'll start with this statement, and then I'll give you some suggestions. So my statement always is, the minute that white people figure out what their role is and what they want to play in justice work, once they do that, I think we will exist in a whole nother fascinating, amazing, and exciting plane as humans. Because I think if we could unleash the creativity of humanity, we could figure this out. So that said, there's some very concrete steps that white men specifically can do. And full disclosure, I live with a white man. I love him. He's my favorite person in the world. And we talk about this all the time. So I don't say this as a black woman to act like I don't have skin in the game, because I do. So the first thing I would say is, who are your accountability partners? Have you purposefully and personally asked, whether it be from your workplace and the people you serve, or from a whole other group of people? And I would argue that some of the participants on this webinar might have the bandwidth and the range to be able to help you with this. You need accountability partners whenever you're doing justice work. So I would actually look to see who is holding you accountable to making sure that you're not acting patriarchal or you're not being a savior, in addition to doing your own reading and your own work. That, to me, is step one. Because in the same way that we want accountability partners every New Year's Day, which happens to be my mom's birthday, around our fitness goals for the year, and people get a health trainer, like, you need accountability partners. So that's piece one. Piece two, when you move to accountability and you know that you are a true partner in this work and you're really trying to make sure that people get what they need, you want a council of individuals of which you will become either a co-conspirator or an accomplice. A lot of people want to stay at the ally level, and I think that's great, and I'm glad people are having an awakening towards that. But we need everybody in a justice-informed world, and everybody deserves a place there. So how we get there? What are we going to do? So at that point, after you have your accountability partners and you have a council, probably made up of people with lived experience in your institution, you want to then think about, what's our way forward? Where's our lane? And how are we really going to be able to gear our services, as well as leveraging whatever power we do have, towards justice? And then who can we partner with? And who can we link with? But you got to start with that individual level first. If you don't have accountability for your own participation in justice work, then it is going to be very much a white savior complex. It is very much going to be very frustrating because, so many people have such good intentions, but they don't know what their actions are. And I would push good leader, white folks who know this could all be different, to think about how. Right? How could this, if black people could have figured out racism, we would have done this already. So I always come back to, we haven't unleashed the power of humanity yet. We do collective things when we work together. We went to the moon, y'all. This is not impossible.
I love that. That's amazing. Thank you so much. This next question comes from Mia. She says, women of color in predominantly white spaces that favor white people need support systems that are absent. Could you please elaborate on how these support systems can be created and sustained in toxic environments?
Yes. So before I got on this webinar, I went to one of my biggest places of support, which also sometimes is one of my biggest places of stress, is Twitter. I have found on social media, and I am myself everywhere. I'll be happy to follow you all if you all follow me. I did tweet it out this morning. I also work on Instagram and Facebook. I have found a community of Black women who use, I'll shout out Feminist Jones and her recent book, Reclaiming Our Spaces. But one of the analogies that she made around social media that I think has been one that I haven't been able to articulate, but that she articulates so clearly is that, you know, especially Twitter functions as a call and response, which is very similar to what Black churches do for Black people. And so I have found that I am one of few onlys in academia, and particularly at a very research-intensive university, right? If you look in my department, there is one other Black person as a faculty member, and she came after I came. And so when you think about academia and when you think about the University of California, you know, realize that 1% of Black people have PhDs and are tenure-track individuals in the country. So I actually rely on social media a lot for support and a lot for validation and acknowledgement. I will also say that the Black Mamas Matter Alliance, and I have to shout them out, which is an advocacy organization that currently is preparing for their second annual Black Maternal Health Awareness Week, which is April 11th through April 17th, has many, many tools for individuals, particularly for Black identified individuals who work at primarily white institutions. And they also have an incredible online community as well as newsletter to help support people who are trying to do this work. I have been pushing using my own power in lots of spaces to say that people should never be an only. You shouldn't be the only person anywhere. And so team hires, looking at community accountability, especially communities that reflect the communities we serve. Really thinking about bringing people in pairs, making sure that women of color are appropriately paid for the work that they do. I never, ever, ever advocate for one person. Even being on this webinar, it's very rare. I've even gotten to the point where if I'm on a panel, I will ask for the panel folks to make space for other Black women. And now when I get asked to speak or give grand rounds, I ask that community organizations be invited, especially women of color-led organizations, to be invited without charge, to be able to come and enjoy that fellowship and to be able to provide some support for me, quite frankly. So I think that it's complicated for people of color who do work at primarily white institutions, but I do think that seeking outside your institution for the support that you need has been a helpful go-to for me. I hope that's helpful.
That's great. Thank you so much. And we have about 2 minutes left, so I just want to be mindful of that time. I have one real quick question left, and then the rest of these questions will definitely be logged, and we will get to them. What kind of things are effective stress reducers for women of color?
So some studies have shown that mindfulness and healthy eating, specifically vegetarian and veganism, have been very, very helpful. Some studies have shown that. I know from my own personal experience, those are helpful, as well as physical exercise, as well as being in community with others. But those are individual traits. I think we need structural, we need to stop improving how Black women adapt to stress. I think we actually need to fix the structural pieces. So for me, I think all of those things are important and necessary to be a healthy human, to have as long of a quality life that you want, whether it's meditation or mindfulness or, empathy or physical exercise or a great diet. But I also think fixing the jacked up structures that are causing us all of this stress is actually our work, because we have power. We're at institutions. We are a collective community that is really wanting to improve health of homeless folks. So to me, that's the rallying cry. Okay, so how do we alleviate or ameliorate some of those structures that are actually causing us stress? I'm a much more upstream kind of person, but there are data that show that mindfulness, that massage, that vegetarian vegan diet, that exercise, or a community with other women of color have been shown to be good day-to-day stress reducers. You can follow the model of Casa Permanente and have music, and make sure you have art and beauty in your world. Being outside, I think, is important. All those things that make us inherently.
That is very helpful. Thank you so much. And I just want to say thank you so much, Dr. McLemore, for presenting today. We are at time, so for any questions that we didn't get to, please know we will provide a Q&A document with those when we post the archived materials. To our attendees, thank you so much for joining today's webinar. A link to the archived webinar will be available on our website, www.nhchc.org, at the conclusion of our spring virtual training. And as a final reminder, please copy and follow the instructions to claim your CME credit for this session. The claim code will only be available now, and credit must be claimed within 3 days. An evaluation of today's presentation should automatically appear in your browser when the webinar closes. If it does not appear, please copy and paste the link provided on the closing page to access the evaluation. Thank you so much. We appreciate your time today, and the webinar